We're taking this, 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 we're taking with a pinch of salt.
Ladies and gentlemen, welcome to another episode of A Pinch of Salt. My name is Andrej Kubernet. I'm a nephrologist from Slovenia. And with us today is Dr. John Stone, professor of medicine at Harvard Medical School and the Edward A. Fox Chair in Medicine at the Massachusetts General Hospital. Dr. Stone is a rheumatologist, so we're very happy to have him at a nephrology podcast. And we'll be talking today about IgG4-related disease, a very mysterious disease, one that we haven't figured out yet completely, I believe I could say, a disease that we're still getting to know. We should remind ourselves perhaps that not so long ago we didn't even know it existed, so it hasn't had a very long history, but it certainly exists. There are patients out there and they need us. As with any rare disease, it's very difficult to gain a lot of experience and feel confident about it when we face our patients. So we're very happy to have with us one of the leading world-renowned experts in this field. John, welcome to A Pinch of Salt.
Andre, thank you very much. It's a pleasure to be here, and I am delighted to help share some of the uncertainty and knowledge about IgG4-related disease.
Well, that's why we have you here, and we're very happy about that. So, like I said, this is a nephrology podcast, and our listeners are mainly, I'm sure, nephrologists, so they're probably aware of the renal manifestations of the disease, like tubular interstitial nephritis or retroperitoneal fibrosis. But we should probably start at the beginning and just ask the most basic question, which is, what is IgG4-related disease, and what are the common renal and extrarenal presentations?
Okay, well, IgG4-related disease, as you point out, Andre, was not even known to be a unique, discrete condition until 2003, when it was recognized in Japan. It is clearly an immune-mediated condition, although some of the specifics of the pathogenesis remain uncertain. It is not clear, for example, that it is an autoimmune disease. There has not been an autoantigen that has been described and validated in this condition, but it is an immune-mediated condition, and it responds nicely to immunosuppressive agents. It is a multi-organ condition. It can involve almost any organ in the body, really with the exclusion of the brain. It very seldom involves the brain parenchyma, but it can really involve just about every other organ. There are 10 or 12 that are most common, so going head to toe, the lacrimal glands and major salivary glands, the parotids and the submandibular glands, and sometimes the sublingual glands. The orbital tissues, particularly the extraocular muscles, the pachymeninges, the pituitary gland, the thyroid gland, the lungs, the aorta, either thoracic or abdominal, the pancreas, the kidneys, and there are probably one or two more, but so it can, those are very commonly involved organs. And the disease typically presents with a mass lesion. The disease is very indolent, and it is not at all unusual for patients to have been sick for many months, even years, before it is recognized. And that is one of the real dangers of the disease. It's so subclinical. It's been described by my Japanese colleagues as being like a dark crow flying through the night.
Oh, that's very Japanese, yeah.
Yes, it is. Now, with regard to the specific renal manifestations, there are several. You mentioned the tubulointerstitial nephritis, and that is the most classic one. The tubulointerstitial nephritis looks pathologically like the disease does in every other organ: lymphoplasmacytic infiltrate, no necrosis, no neutrophils, no granulomatous inflammation. The disease tends to target veins, so there is very often an obliterative phlebitis, and there's a characteristic but not pathognomonic fibrosis called storiform fibrosis. And all of that happens in the kidney, in the tubulointerstitial region. That probably accounts for 90% of the direct renal involvement. In about 10% of cases, and sometimes occurring simultaneously with the tubulointerstitial nephritis, is a membranous glomerulopathy. So it's very interesting to think about these two different pathology presentations and whether that speaks to different pathophysiologic mechanisms, we don't really know. But membranous GN and tubulointerstitial nephritis are the typical intrarenal manifestations. And then a very important way in which the kidney can be impacted is an area that I forgot to mention in my earlier listing, retroperitoneal fibrosis, an extremely common process. Probably a third of patients with IgG4-related disease have retroperitoneal fibrosis. And the location of this retroperitoneal fibrosis is typically in a peri-aortic distribution, beginning in the infrarenal area and extending down to the iliac vessels. This location is really crucial because it is, as you know, at the iliacs where the ureters cross over on their way to the bladder. And
Exactly. Yeah.
the inflammation often reaches out and entraps the ureters, leading to hydronephrosis. And this can be a source of great renal morbidity in these patients.
Yeah, membranous really is an interesting presentation because we knew that in membranous, the classical one, not related to IgG4, IgG4 antibodies are actually the main antibody type in normal, I would say, let's say, or the usual variety of membranous, and they are targeted to an antibody. So that version is an autoimmune disease. So how do we actually establish a diagnosis? So ideally, or most cases, you probably need a biopsy, right? I mean, the kidney biopsy is simple. We're that's bread and butter for us. The retroperitoneal fibrosis is more difficult because you never quite know, is this lymphoma, is this sarcoma, is this actually IgG4? Sometimes in CT scans, it looks very aggressive, like invading into the towards the artery. So the radiologist sometimes think it's malignant, but then it's difficult to convince somebody to do the biopsy. Is it the urologist? Is it the cardiovascular surgeon? How do you do it?
So I love pathology and I love pathologists. They've taught me a lot. But one of the things that I think is most important about this disease is that it is the clinician who makes the diagnosis. That's not to discount the importance of pathology, but the pathologist, although there are typical pathology findings in this condition, there are no diagnostic pathology findings. So in ANCA-associated vasculitis, if you see necrotizing glomerulonephritis, then with the right set of serological findings, you can nail the diagnosis for sure. But there is no tissue in which the pathology provides absolutely diagnostic tissue. So the diagnosis has to be approached by understanding what the clinical manifestations are, which organs are affected, what the serological findings are. The serum IgG4 concentration is very helpful there. So is hypocomplementemia. Are there radiology findings? So with regard to the kidney, on CT scan, one sees hypodense lesions near the renal cortex. And then the biopsy findings we have already talked about. And so the clinician has to put together findings, data from all of these areas in order to make the diagnosis. You are correct about the difficulty in diagnosing disease in the retroperitoneum. I am very often persuaded by the radiologic distribution of disease that I mentioned earlier, the infrarenal area surrounding the aorta, extending down to the iliacs. If one sees that, then one can be reasonably confident that it is IgG4 related disease. When the fibrosis appears in another part of the retroperitoneum, it's more difficult to be certain. The challenge, as you have implied, is getting a good piece of tissue um, from the retroperitoneum. If because of the periaortic location, radiologists are often not very excited about going near the aorta with a needle. So very often one has to make an empiric diagnosis and follow the patient's response to treatment to make sure that that's the right answer.
Yeah, so you mentioned this typical presentation, which goes around the abdominal aorta and towards the iliac arteries, and it's not like a mass, right? It's more like a sheet, like it's like a uniform sheet around the aorta, right? It's not like a
Yeah,
bulging mass.
it's a periaortitis, and
Mhm.
sometimes there can be a true aortitis as well. And the distribution sometimes only involves the iliac areas, or maybe just one iliac artery.
Mm.
That is very typical, and when I see that,
Mhm.
I'm generally pretty sure that this is IgG4 related disease. But making the diagnosis in patients with RPF, retroperitoneal fibrosis, is challenging for several reasons. Usually, the disease is localized to the retroperitoneum. Usually, the serum IgG4 concentration is not very high, and it can be normal. Usually, patients don't have hypocomplementemia when they have retroperitoneal fibrosis only as the only site of disease, and access to a good biopsy is unusual. We should probably say a few words about the hypocomplementemia,
Yes, yes.
which initially, for a number of years, was thought to be a manifestation exclusively of renal involvement, the tubulointerstitial nephritis. It turns out that that's not the case. Our group published a paper just last year indicating that hypocomplementemia is actually a manifestation of overall um, disease activity and correlates with disease in a number of organs, not just the kidney. Um, the association of hypocomplementemia with renal disease was made early on, and it turns out to be not only associated with renal disease. And it's interesting that only 30 or 40% of patients have hypocomplementemia as defined by low C3 or C4, but it is quite possible that the complement cascade plays an important role in IgG4 related disease. And a lot of patients may not have uh, low serum complements, but sort of low normal. And there's speculation that the complement cascade does actually play a role in the disease, but this really needs to be studied further.
So you've mentioned also measuring IgG4 in the serum, how that can be helpful. It's not always high, like you said, in retroperitoneal fibrosis, but it can be helpful. And I believe the cutoff is 135 milligrams per deciliter, right?
It varies from lab to lab.
Hmm.
With the assay we used to use, it was 135 milligrams per deciliter. With our current assay, it's 86. And so it's going to vary from lab to lab according to which assay they are using.
Okay.
The
And does it drop?
serum
Does it drop with successful therapy? Do you see a drop when the therapy is successful?
It does indeed, yes. The serum IgG4 concentration tends to correlate with disease activity. It correlates with the number of organs affected. The more organs involved, the higher the serum IgG4 concentration is likely to be. It does improve and normalizes over time. or moves toward normal over time. Typically, it drops dramatically after the first, within a couple of weeks of the first treatment, but then it declines more slowly after that. Sometimes not quite reaching normal before the patients flare again and need to be retreated. So the IgG4 we don't believe is causing the disease. It's important to say that. We think that it is actually serving a counter-regulatory role, trying to inhibit the primary immune response, but failing to do so. So it's an
Okay.
ineffectual counter-regulatory mechanism. The IgG4 rises and rises and rises until effective therapy is administered, and then it finally falls. But
Okay. That's interesting. Yeah.
yeah, it's a bit counterintuitive, and in the early days, I mean, after all, we call the disease IgG4 related disease, but we don't think that IgG4 causes the disease.
Okay, so let's say that you found the disease in one particular organ. Let's say it's retroperitoneal fibrosis, for example. Now you've mentioned that this is could be potentially a multisystemic disease. How much, in ANCA vasculitis, we usually do some kind of staging, looking for the, disease in other organs, particularly the eyes, because they can be very asymptomatic. So is there a kind of staging here in IgG4? Or if there's no clinically obvious manifestations, you don't really look specifically
Now,
for
it's
other
important
organs.
to look because the disease can be so indolent and subclinical. The patient may seem to have only involvement of the major salivary glands, but in fact, there may be raging pancreatitis that you
Mm.
don't know about unless you perform a CT scan of the abdomen. So I typically perform CT scan of the chest, abdomen, and pelvis for all patients. And if the patients have orbital disease as well, not lacrimal gland, the lacrimal glands are really outside of the orbit, but if they have proptosis, if they have extraocular muscle involvement, then I would perform a dedicated CT scan or MRI of the orbits as well.
Yeah. What about PET CT? I mean, I've read and seen personally that it can light up really nicely on PET CT as well. Do you use that?
So PET can be useful for determining the extent of disease at the outset. It is not universally helpful in following disease activity, partly because the radiologists really don't know how to interpret persistent changes in FDG or persistent FDG uptake in organs over time. It's not only active inflammation that can cause that.
Yeah.
So a PET scan, if one can get it, is helpful in detecting sites of disease. Whether it really changes overall management at the beginning is not clear. Whether it really adds something more to just a CT scan, I don't think has been demonstrated, but it's fine to get if you have access to it.
Okay. So moving on to therapy, right? So what is the standard therapy that you give? And does the approach depend on which organ has been affected or how many organs, the extent of the disease? How do you approach the initial treatment?
So across the world, the cornerstone of therapy remains steroids. This is problematic because the disease tends to involve middle-aged to elderly individuals. It has a male predominance, which is interesting and not understood. And the disease tends to target the pancreas. So if you've got a 60-year-old man who is maybe a little obese and hypertensive and borderline diabetic, and the patient has damage to the pancreas, and you have to put the patient on a long course of prednisone, that's going to cause obvious problems. So that is an issue. And these patients are typically very brittle diabetics. Patients with autoimmune pancreatitis very often have osteoporosis to begin with. So steroids are exactly the worst kind of therapy to have to rely upon in this disease. It is not clear that the typical conventional steroid-sparing medications actually spare steroids. They may seem to help, but then when the steroids are stopped, it's very often clear that they're not helping very much. One biologic therapy that has been shown now to help very nicely is B-cell depletion. For a long time, we used rituximab when we could get it off-label for these patients. Most recently, so rituximab is an anti-CD20 agent, B-cell depleting agent. Very recently, just in November, we published the first worldwide clinical trial of inebilizumab, which is an anti-CD19 B-cell depleting agent. And this was published in the New England Journal of Medicine, and we hope that the strongly positive results from that trial will lead to drug approval in North America and Europe and everywhere, we hope, over time. The question of whether every patient needs to be treated and how they should be treated really needs to be taken on a case-by-case basis. So this week in clinic earlier, I saw a young a woman who had classic, what we call Mikulicz syndrome,
Mm.
lacrimal, parotid, and submandibular gland disease. No other disease that I'm aware of, although the full workup is pending. So how do we treat this patient? One can take a couple of approaches, several approaches. Watchful waiting is one. That's not appealing in her case to her. She doesn't like the appearance of her glandular enlargement. One can treat her with steroids. But she is worried about weight gain and skin changes with that. But a short course of steroids, 8 weeks or so, beginning at 30 or 40 milligrams a day, would be a reasonable approach. And it is also, I think, not unreasonable to think about B-cell depletion in that patient, assuming that she's fully vaccinated against COVID and up to date on her other vaccines. In a patient like that, it may be a little bit more debatable about whether one should use B-cell depletion early on. But in a patient who has multi-organ disease, internal organ involvement, pancreatic, kidney disease, lung disease, there's no question that I think one needs to go to B-cell depletion as early as possible. B-cell depletion, as was shown in the Mitigate trial, which studied inebilizumab, B-cell depletion is far superior to steroids as an approach to long-term remission maintenance, and it is likely to spare a lot of the toxicities associated with steroid use. So I think it's unequivocal in those patients that we should be going to B-cell depletion as early as possible.
Okay, that's very useful information. And the corticosteroid regimens that you mentioned are pretty short, a couple of months.
It varies according to region, so geographic region. In North America and Europe, we've tended to use courses 3 to 4 months of prednisone. So maybe starting at 40 milligrams a day of prednisone. And that for a patient with multi-organ disease, and then trying to taper patients off completely over 3 months or so. In Asia, there has been a contrasting approach. In Japan and China and Korea, for example, the physicians usually leave patients on some dose of steroids, 5 to 10 milligrams of prednisone a day, for long periods of time.
Mm.
And this does lead predictably to substantial steroid-related morbidity.
Yeah, of
So
course.
that's not an approach that I endorse, but that approach has been informed by the absence of an effective alternative to steroids until recently.
Of course. So how do you assess effectiveness of therapy? I mean, it depends on the presentation. Obviously, for tubular interstitial nephritis, we're very well aware what happens. The kidney function improves. For membranous nephropathy, the nephrotic syndrome improves. But let's say for retroperitoneal fibrosis, this is not always a very large mass. You probably don't see a disappearance in mass, or do you? And of course, if you have hydronephrosis, you might get a relief of the hydronephrosis, I guess, and that would be a marker of successful therapy. So how do you assess success in these cases?
Yeah, so that's a really good question with regard to both the kidney and the retroperitoneum. So it is concerning what happens in the kidney. We don't know enough about the natural history on treatment, but what we do know suggests that patients can have substantial sclerosis of the kidney, even if they seem to have a very nice clinical response to therapy. And the same is true in the pancreas. So the kidneys may be enlarged at the time of diagnosis, but then there is substantial shrinkage and sclerosis over time, even if they seem to have had an excellent response to therapy. So that's worrisome over the long haul. And we need more studies of the natural history on treatment of renal disease. With regard to, and I should say with regard to renal disease, there are typically serological markers that are helpful in following response to treatment. Serum IgG4 hypocomplementemia, for example. With regard to retroperitoneal fibrosis, it is more problematic. Sometimes imaging can be helpful, but very often the clinical responses are far better, fortunately, than the radiologic responses. So there may remain some areas of fibrosis around the aorta and other places. It seldom vanishes completely because it's probably been long-standing by the time it's been diagnosed and treated. But even a little bit of improvement can be enough to get patients' ureteral stents out or to get their nephrostomy tubes out. And that is a huge improvement in quality of life.
Yes.
So I have seen some patients who were diagnosed early on because the location of their retroperitoneal fibrosis led early on to hydronephrosis, flank pain. So they were diagnosed early. Some of those patients can respond brilliantly to steroids. The fibrosis or inflammatory response goes away very quickly, and they can just be followed. The same is true for patients treated with B-cell depletion. And even patients who've had long-standing disease, indwelling stents for years sometimes, or nephrostomy tubes. With B-cell depletion, we've had great success in getting these stents out and the nephrostomy tubes removed. So it's definitely worth being aggressive for these patients. And what I typically do is treat patients aggressively, and then after 3 months of either steroids, a steroid taper, or B-cell depletion, give them a trial of having the stents removed. And very often they can come out and stay out, even if there's still some fibrosis left.
And then see what happens, I guess, right? You don't give rituximab for very long periods of time either, I guess.
No, I don't. That's true. I don't typically retreat patients every 6 months. Sometimes we do that for ANCA-associated vasculitis patients, at least for a time. I don't think that IgG4-related disease, these patients need that. They can be followed, and often there are serological biomarkers that indicate that when they should be retreated. That's often not the case with retroperitoneal fibrosis. But RPF is very slow, and I have seen a few cases of recurrence. One patient, after getting his ureteral stents out and having a wonderful celebration of that, a couple of years later, his disease recurred and he had to have nephrostomy tubes placed, which was a disaster. But after retreatment, we got the nephrostomy tubes out, and he's been stable for years. So I don't usually retreat patients with RPF either, but it's harder to know when they need to be retreated as a prophylactic measure. It's always sort of a gut sense call.
Very informative stories. I'm very grateful that you're sharing this with us because most of us don't have this experience, of course,
Yeah,
but we
I've
will
learned
stumble
from
on a
the
patient from
school
time to time.
the school of hard knocks.
The School of Hard Knocks, exactly. So, just one quick, short additional question. Are you aware of any um, anecdotal or other evidence about the outcome of kidney transplantation if somebody has kidney failure with IgG4?
I am not aware of a single case, actually. There have been patients who have undergone renal transplantation, but there's no reason, no a priori reason for thinking that they would not do very well with
Yeah,
renal transplantation. We used to say that lupus patients shouldn't be transplanted, but that's obviously incorrect. And I
true.
think that patients with IgG4-related disease would do very well with renal transplantation.
Yeah, we have one single patient and he does very well. I mean, there was no issue, no problems. So we've come to the last and usually most difficult question, or the one that people complain the most, which is which book, two songs, and luxury item would you take to a desert island, John?
Okay, that is a tough one. Um, I would say my favorite book of all time is a book called Cutting for Stone. It doesn't have anything to do with me. But it was written by a physician, Abraham Verghese, and it is about a physician who actually was at my hospital, Massachusetts General Hospital. It is a fictitious account, but it is a wonderful story and every physician should read it. So that's the book that I would take. It's due for a reread. With regard to songs, I'm currently on a Bob Dylan kick because of the movie A Complete Unknown, which I've already seen twice. So I think I would have to bring a Dylan soundtrack, maybe one of him singing with Joan Baez. And luxury item, I guess it would have to be my iPhone so that I can continue my struggles in trying to perfect Spanish, which is an increasingly important language to speak in the United States. And I've been
Yes, I can imagine.
doggedly trying to do that for some years. So I would take my iPhone so I could continue to practice on Duolingo.
Yeah, I was I'm very hesitant to see the film. I regarded doing a biography of Bob Dylan while he's still alive, like as a sacrilege of sorts. But my daughter went to see it, and she said she thought it was pretty good. So interesting. We had a podcast with Dr. David Goldfarb from Columbia.
Hmm.
He's a kidney stone expert. He's also a huge Bob Dylan fan.
Uh,
And yeah, I've never heard about the book, but I'm a big fan of physician authors like Michal Bulgakov or Somerset Maugham.
oh
I
yeah.
think physicians have a wideness to their lifetime experiences, which can make good novels, I guess.
Yeah, there's a chapter. Thanks for bringing up Somerset Maugham on human bondage is his book.
Yes,
And
yes.
there's a wonderful chapter in that book where he is in a ward with a very experienced clinician, and the things that he saw and wrote about so beautifully were just really wonderful reading. It's probably the best medical writing that I've ever enjoyed. And but Cutting for Stone is an entire book that is just a wonderful read. So I recommend it to your listeners.
Thank you, John. Thank you. You've offered so much insightful data, interesting stories. I think we'll all benefit a lot. But of course, we've also I guess recognize that we don't know enough about IgG4 while listening to you, but that's the nature of the world. We have to struggle through it, right?
Well, knowledge is definitely evolving. It's evolving fast in IgG4 related disease. And I'll just say one last thing. It really is a remarkable disease for studying the human immune system because the disease is slow, as I've emphasized, and you can treat a patient who's not been previously treated before, not even with prednisone. And then you can observe what happens to the immune system after that by sampling the blood, even by rebiopsying an organ if that is possible. And one can glean lots of insights into how the human immune system works. And that's been a real pleasure for me working with basic scientists to try to understand this disease.
Great. Thank you for trailblazing through it. Thank you for helping us getting through our cases as well at some point. And that's been all for this episode. Thank you, John.